And oh, got it. Okay. So first of all, I just want to welcome you. My name is Kelly Stadjahar, and I'm a professor here at the School of Nursing and at the Institute on Aging and Lifelong Health, and the Canada Research Chair in Palliative Care, Aging and Community Health. I just want to begin with a territorial acknowledgement here from the University of Victoria, where we acknowledge and respect the Lekwungen peoples on whose traditional territory the university stands, and the Songhees, Esquimalt, and Wasanich peoples whose historical relationship to the land continues to this day. At this time, we find ourselves connecting remotely from different parts of Canada, and I'd like to collectively acknowledge the lands we all occupy, whether treaty or unsurrendered. And I would invite you to put your land acknowledgement in the chat if you would like to do that. I'm really pleased to introduce Dr. Tara Horrill as our inaugural speaker in a series we hope to continue that's supported by my Canada Research Chair. Dr. Horrill is an assistant professor at the College of Nursing at the University of Manitoba. The research she's going to present this morning focuses on critically examining equitable access to oncology care and cancer disparities among Indigenous peoples in Canada. And her work focuses more broadly on the important issues of equity and cancer care. Dr. Horrill began her nursing career in a busy urban emergency department, and after several years found her way to oncology nursing, where she worked as a primary oncology nurse at Cancer Care Manitoba and in clinical research. She graduated with her PhD, Tara, I can't remember if it's 2000 or 2001, and she was a Michael Smith Health Research BC postdoctoral fellow before taking up her assistant professor role. Tara is an amazing speaker. She's incredibly bright, and I hope that you're all going to enjoy our conversations with her this morning. I'm going to be sharing Tara's screen, the screen, as we had a little bit of technical difficulties this morning, but I'll let you take it away, Tara.
Thank you very much. Can everyone hear me okay? Okay. Thank you for that lovely introduction. It's really wonderful to be here. And if you could advance to the next slide. I also want to acknowledge that the land that I live and work and play on is Treaty 1 territory, which are the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and the homeland of the Métis Nation. And I also want to mention too that land acknowledgements are really only a small part of cultivating strong relationships with Indigenous peoples in Canada. Acknowledging territory and Indigenous relationships, peoples should take place really within the larger context of genuine and ongoing work to forge real understanding and challenge the legacies of colonialism. So yeah, as Kelly mentioned, please feel free to put your own land acknowledgement in the chat. Next slide. So just to give you a bit of an outline of what I will be talking about today, I'm going to start by giving a brief overview of health inequities and Indigenous peoples, and then I'll get into some of the research that I have done, discuss some of the barriers faced by Indigenous peoples when accessing oncology care, as well as some of the roles and the work that nurses do to address these barriers. And then I'll close by talking about some of the ways that we might move forward to create a more equitable system. And I do want to clarify upfront that when I use the term Indigenous peoples, I'm referring today to 3 distinct groups in Canada, and that includes First Nations, Métis, and Inuit peoples. Next slide. So what are health inequities? Next slide. Health equity, I think, is a bit of a buzzword right now, but what does it actually mean? And I think it's important to define what we mean by health equity. It's often confused with other concepts or used interchangeably. And so For the purposes of my work in today's presentation, we're understanding health equity as the absence of unfair and avoidable or remediable differences in health among population groups, however those are defined socially, economically, demographically, or geographically. Next slide. And conversely, health inequities are those differences in health that are socially produced, they're systematic in their distribution across a population, and they're unfair. And health inequities are really created and maintained by social and structural determinants of health, or more simply, the circumstances and conditions that we are born into, we grow up in, and we live and work and age in. So social determinants of health, of course, include things like one's living and working conditions, education and employment, income, socioeconomic status, healthcare access, and so on. And those determinants of health are shaped by structural forces, which might include things like public and social policy, economic contexts, social values, political philosophy, and so on. Next slide. Now, when we talk about determinants of Indigenous peoples' health, it is important to recognize that there is yet another layer, and that is related to colonialism and systemic racism. And so for Indigenous peoples, colonial and racist ideas and philosophies have historically, but also continue to have major impacts on the economic context for Indigenous peoples, for example, or on legislation, policy, specific to some Indigenous groups in Canada. And so in that way, colonial thinking has very much shaped the structural determinants of health, which trickle down to the social determinants of health and so on. A very relevant example of colonialism and systemic racism can be found in the Indian residential school system. And I'm sure many of you or all of you are familiar, but this system was founded on racist ideas of Indigenous peoples as being inferior and forcibly removed children from their homes. And those structures and policies have, of course, continued to have devastating and wide-ranging impacts on Indigenous peoples. Next slide. And so what is the difference between equity and equality? In this context, health equality really means that each individual or group is given the same opportunities and access to social determinants of health. That's represented by those blue boxes that people are standing on to achieve good health outcomes. And those outcomes are represented by the fruit in the tree. And on the other side, equity acknowledges that the playing field is really not level. There's some groups or people that experience disadvantages for many different reasons, and they may need access to more resources to level that playing field and provide opportunities for those good health outcomes. Next slide. And so if we take this idea of equity, those with the highest health and social needs should have the highest level of access to health and social services. In reality, what we see is often the inverse care law at play, where access to healthcare tends to be lowest among those with the highest need. So how do health equity, access to care, and determinants of health show up in reality and in the lives of Indigenous peoples? Next slide. We know that the health of Indigenous peoples globally is a significant concern. Here in Canada, Indigenous peoples will really experience very startling differences in health outcomes and bear a disproportionate burden of illness and suffering. And so, for example, this is a well-known statistic, life expectancy for First Nations and Inuit peoples is on average 10 years lower than for non-Indigenous Canadians. In terms of cancer, we've seen some quite alarming trends over the past few decades. We've seen rising incidence of several cancers among Indigenous peoples, which might be actually stable or declining in the non-Indigenous population. So, for example, a recent BC-based study showed the incidence of lung and colorectal cancers was actually increasing among First Nations peoples, where it was decreasing in the general population. We've seen patterns, or we do see patterns of diagnosis where Indigenous people are being diagnosed with quite advanced cancers, which could have been detected through simple screening services. And we're seeing cancer-related mortality outcomes that are quite a lot worse than for non-Indigenous Canadians. So, for example, in a study we did a few years ago, that was Manitoba based, we found that a higher proportion of First Nations people were diagnosed with stage 3 and 4 cancers, so those are advanced cancers, than all other Manitobans. And this is really despite a system that's publicly funded, that has a an espoused commitment to universal healthcare access. These may be issues that you've seen in your own practice, depending on what area you work in. And I really began seeing some of these patterns in my own practice a number of years ago and started to ask questions to those around me as to why this might be happening and why I was seeing what I was seeing. And interestingly, I most often received one of two responses, either that these were racial differences or that these differences were because of so-called lifestyle choices, which really didn't sit well with me and eventually formed the basis of my doctoral research, which is the focus of this presentation today. And I was especially interested in issues around access to oncology care and how that was perhaps impacting some of the disparities that I've highlighted here in terms of late-stage diagnosis and high cancer-related mortality. And so, next slide, that became the purpose and the focus of the research that I'm going to discuss today, to really critically examine some of the barriers to accessing oncology care among Indigenous peoples, as well as the perspectives of oncology nurses in terms of what and where they were seeing challenges to accessing care for this population, and also what they saw as their role in terms of addressing or improving access to care. Next slide. So briefly, in terms of methods, this research was actually 3 separate studies. First was a scoping review of the literature looking at barriers to accessing oncology care for Indigenous peoples across Canada. The next, I conducted an online survey, which included 70 oncology nurses from across Canada working in quite diverse roles and settings. And then I followed this up with interviewing 15 of those nurses to get a more in-depth understanding on their perspectives in terms of barriers, challenges faced by Indigenous patients when trying to move through the cancer care system. And so the findings that I'm presenting today are really a sort of a synthesis of all of these projects. Next slide. So what do we know in terms of barriers to accessing oncology care? Next slide. So some of the more common and obvious challenges would include things like lack of access to transportation. Sometimes this means that transportation is not available at all, or perhaps it's unreliable or unaffordable or not convenient. This is an especially important challenge as many Indigenous patients will live in rural and remote areas. Communication can be problematic in terms of patients who do not speak or understand English. And on the flip side, the expectation in our healthcare system that everyone does speak or understand English. Or perhaps they don't have reliable or consistent access to a phone or a computer or internet. Poverty and financial ability to pay for expenses that are not necessarily covered by provincial health plans or by federal coverage for some status First Nations. One nurse actually told me a story of an Indigenous man who was suspected of having colorectal cancer after a mass obstructing nearly his entire colon was found. And he was scheduled for a colonoscopy several times, but he had no way of covering the cost of the bowel prep solution. So he was living on social assistance at the time, and it provided so little income that the approximate $20 cost of the bowel prep was too much, and that cost was not covered by the health system. And then lastly, even just patients' knowledge of the healthcare system, how it works. It's a very complex system. Their ability to advocate for themselves, all of that impacts their ability to access oncology care. Next slide. And then we have some issues specific to the healthcare system, how it's designed and how it functions. So access to primary care can be very challenging, and this is especially true for many Indigenous people who live in northern or remote settings where primary care is very limited. There might be a high staff turnover, and access to care is inconsistent. And really, primary care is often the gateway into the cancer care system. So if you're having trouble accessing primary care, it's going to affect all the rest of your journey. And if you work in the healthcare system, you will know very well that our current healthcare system functions very much in silos, and those silos or parts of the system do not always communicate well or work well together. Some nurses describe the system as broken or fractured or messy. And then lastly, on this slide, there were the physical environments in hospitals and clinics and so on that tended to feel intimidating or unwelcoming to Indigenous peoples. Next slide. So this nurse is really speaking to that feeling of walking into a physical space and what that might feel like for some Indigenous patients and how that can create challenges. Even just walking into an institution, you're walking into an established Western institution. And even if it's there to help you, it is still often cold and medical. And I would suspect that historically Indigenous people have not had good relationships with institutions, right? So looking at child welfare systems, residential schools, or anything like that. Next slide. Many oncology nurses highlighted how Indigenous patients' experiences in healthcare settings are themselves a barrier to accessing care. So judgment was identified by Indigenous patients in some other studies as a significant issue in terms of accessing care. One way this came across in my own research was in how Indigenous patients were deemed as compliant or non-compliant. So, for example, patients who followed prescribed treatment or attended all of their appointments were described as cooperative, appreciative, not defensive, whereas patients who were not able to follow the treatment plan or who missed or canceled appointments were judged in a very negative light without really any consideration of the contextual circumstances or the barriers that they might have been facing. And one nurse I spoke to described how in the case of non-Indigenous patients, staff might attribute their struggles or missed appointments to financial or mental health challenges, to name a few. But in the case of Indigenous patients, the narrative was often their struggles were because they were Indigenous. Nurses reported instances in which patients were labeled as drug seeking and then did not have their symptoms adequately addressed. One oncology nurse described how a patient with stage 4 cancer had difficulties many times with their pharmacy who did not want to dispense pain medication to the patient because they felt the dose was inappropriate. And there was an assumption that the patient was drug seeking. She described how this patient came to her one day and was extremely tearful and made the statement, "I wish I was white, then I wouldn't have to be in pain." And then finally, negative healthcare experiences can come in many different forms, but a few examples of how this plays out. One nurse navigator who worked closely with many Indigenous patients described how challenging it was for these patients to even interact with receptionists. So she told me how people in the Indigenous communities she worked with often referred to the receptionists at the cancer agency as rejectionists. Another nurse described a particular healthcare provider that she worked closely with and how she witnessed on several occasions when this provider started a conversation with an Indigenous patient about potential cancer treatment options. They did so in a way that she said broke the relationship. So their mannerisms and the subtly insensitive way that treatment was offered by this provider, specifically to Indigenous patients, meant it was often declined. And so it's not hard to see how these types of experiences can result in patients who avoid or delay accessing cancer care services. Next slide. In this quote, an oncology nurse is describing how an Indigenous woman who was unable to attend her appointment was judged as non-compliant. So the staff deemed her uncooperative because they had arranged for her to have a last-minute procedure on a Friday afternoon. And of course, she had a medical transport back to her community. So she has to catch her van at a certain time. And so she declined the procedure. And then they kind of labeled her as uncooperative. Well, if she doesn't get on that van and go home for the weekend, she has no hotel and no money in the city. Next slide. Oncology nurses in both the survey and interviews spoke about how anti-Indigenous racism is a significant barrier to accessing healthcare of all kinds, including oncology care. And this includes the more obvious instances of overt interpersonal racism, and a number of nurses told me about witnessing these kinds of interactions, but also the microaggressions, which are much more subtle and common. But this also includes sometimes less obvious structures of racism that are embedded in policies or institutional processes. And I think what's important is that these experiences of racism are not seen as like one-off events, but they're often layered with repeated experiences of racism over a lifetime, as well as layered onto experiences of patients or their family members within the residential school system. One of the nurses I interviewed articulated these experiences very succinctly in stating racism is just the water that we swim in. And so when I raise racism as a major determinant of healthcare access and health inequities, it's not in a blaming or shaming way, but I think it's actually very helpful to accept that it is everywhere. And less of a matter of, who or what or if, and more of a matter of accepting that this is our reality and starting to think about how we can address it. Next slide. One oncology nurse I interviewed described this in terms of discrimination and how it affects patients. Discrimination definitely affects access. I think that is why when you look at our people as a population, we show up in later stages of cancer. And I think that a lot of it is because of the discrimination people feel within the system, the mistrust. And so people leave things until it's so far gone that they can't tolerate it anymore. And one important and interesting finding from my interviews with oncology nurses was how they described and highlighted the intersectional nature of the barriers to accessing care. And what I mean by that is that often barriers tend to be overlapping and tend to have this compounding effect where each barrier encountered makes the next one more challenging to overcome. And that's sort of what I'm trying to illustrate here. Another way to maybe think about it is to think about a knot or a braid and how we often see that a lot of these barriers are intertwined with others. And it's really hard to start disentangling what is happening. And it's really that layering or intersecting effect that severely limits access to care. So it isn't just a matter of, for example, providing transportation to address a geography barrier or sending a mobile breast screening van into remote communities, but rather appreciating these are extremely complex barriers that are hard to disentangle, and we need to really think through how to address them. So I'd like to share a story with you as a way of illustrating that layering and compounding I'm talking about, that web of challenges. And this story is based on an actual patient's experiences, although some details have been changed to protect the identity of the patient and the healthcare provider. So this is a story of a First Nations patient living in a Northern Reserve community. And so from the very first encounter they had with the healthcare system before diagnosis, they had attended a nursing station to try to figure out why they were feeling so unwell. And immediately in that first encounter, this patient was viewed as drug seeking and unfortunately given a couple of Tylenol 3s and sent home. Their symptoms did not improve and only became worse. And so they tried several times to get care at the nursing station, but there really wasn't a lot that could be done there, even an x-ray not available locally. And so at one of the visits to the nursing station, the staff had said, well, okay, we'll send a requisition for a CT scan. And then that was scheduled for 6 or 8 months down the road. But unfortunately, the patient really couldn't get to another option in terms of healthcare. And so they had to get creative. This was an elderly person. So it was quite significant for them to go outside of their community. But the patient ended up acting as a medical escort to a family member because they needed to find a way to get out of the community and get care. So this patient sought care in an emergency department, but again was considered drug seeking. In the emergency department, they prescribed him something different for the pain and did order another scan, which would be done sooner. But the patient had to find a way of staying in that city because the family member they were going to be an escort to was returning home. And the federal benefits that they were entitled to were only going to cover the expenses while they were serving as an escort. So as soon as they were not an escort, they had to find their own way to stay in that community. And so the patient found a place to stay, basically couch surfed with someone they knew, and eventually did get a CT scan. And when they did, it was found that they had 6 metastatic fractures and a very large tumor. So this is a very significant and very advanced cancer. The patient eventually got to the cancer center and saw an oncologist, but continued to have problems in the system. And in this situation, as much as the oncologist and other team members, wanted to try to address the barriers that were happening, they were so compounded, there were so many gaps that the care the patient received really was inadequate and came quite a lot too late. So this story really begins to paint a picture of a healthcare system that is not universally accessible, and one in which, some groups experience significant health inequities in healthcare access that have very tangible effects on their health. Next slide, please. And so I'd like to turn now and dive into discussing the work and the roles of oncology nurses. Next slide. And as part of my research, I asked nurses what role they felt they either had or could play in terms of improving access to care for Indigenous peoples. And what I found was that many nurses worked as mediators of access to oncology care. You'll have to click through these, Kelly. They were active in the process of helping patients gain access to care, and in many cases, they worked on behalf of patients to bridge some of those gaps through their work as care coordinators, as advocates, as navigators, and educators. And just to be clear, these were not necessarily formal roles, but some of their informal work. Next slide. So nurses addressed access to care issues by coordinating care on behalf of patients to ensure, or as much as possible, try to ensure seamless delivery of care. Some nurses talked about how they were the go-betweens or the glue that held the multidisciplinary team together and how they coordinated the work of these teams. Nurses liaised with community care settings to make sure patients were getting the necessary care closer to home when possible. Often this required significant investments of time and energy. So for example, in the quote that you can click on, this nurse talks about getting an Indigenous man access to seniors benefits, social work, speech language pathology, diet supplements, and so on. And, that takes quite an investment of time. Next slide. Nurses also guided patients in terms of trying to navigate the oncology system by troubleshooting barriers and trying to connect them to resources. Some nurses recognize the need to further their own understanding of the context or the communities where Indigenous patients were living. So for example, understanding what resources and services are or might not be available in some communities. Many nurses discussed referring patients to a formal nurse navigator, but some also saw that supporting patients to navigate the system was part of their own role. So for example, in this quote, I do as much legwork as I can, providing names, numbers, services, and so on. Next slide. And as nurses, we often occupy this sort of middle or mediating position between patients, other healthcare providers, or the larger team, and then the broader healthcare system. So a fairly common response in terms of how nurses could improve access was around using that middle or mediating position to advocate. And most often this was talked about in terms of advocating on behalf of specific patients or their families to get access to a particular service. But a few nurses did talk about the broader advocacy roles that nursing or nursing organizations could take, like advocating for policy or health systems change. Next slide. Developing trusting relationships with patients was talked about by some nurses as one way to improve access to oncology care. For some, this might not seem intuitive, but I think it's really important to unpack how this actually affects access to care. So building those trust, avoiding judgment, recognizing one's own biases really helps to make patients feel safer. And those feelings of safety and being respected mean that patients are more likely to access care. And these relationships are especially important given really the historical and current context of Indigenous peoples in Canada, the fear and the distrust of the healthcare system that is very rightly common among Indigenous people. So for example, the historical experiences of residential schools or Indian hospitals have resulted in, massive personal and collective trauma and a distrust of government institutions, and that includes healthcare institutions. And in this quote here, in terms of current experiences, one nurse who worked in an inpatient pediatric oncology unit talked about how for many Indigenous families, the hospital is actually a place where kids are taken from their families, or a place where child and family services is called. And so that fear and that distrust play a massive role in sometimes whether or not services are accessed, or when they might be accessed. And so I think it's really important to understand the current issues of healthcare access also within the historical context as well. Next slide. So I talked a bit about how some of the work nurses are doing in terms of trying to address gaps in care and access issues. But it was also very obvious in the survey responses and in the interviews with nurses that they were working within the confines of a broken system. And obviously there were limits to what nurses could do within the system and within their nursing roles, especially in terms of social and structural barriers faced. And I think this second quote articulates these limits really well. This nurse was telling me about a specific patient and the lengths that she went to address different barriers to getting cancer treatment. But the reality is that, despite bringing in all the resources that she could, there really wasn't any way for her to level that playing field. Next slide. So this is a story told to me by one of the nurses I interviewed that I think really starts to exemplify how difficult it is to level that playing field and the challenges that nurses themselves are facing. So these are her words. There was a case where it was just layer upon layer of social problems that made us have a lot of difficulty getting her to diagnosis. And in the end, I couldn't get her to diagnosis. I couldn't do it, but we were successful in reaching out to her whenever she needed us. She did not have good living circumstances, was suspected of having colon cancer, and she lived in a hotel, was always broken into, and she had no ID ever. And of course, if your doctor is sending you for a colonoscopy, you need your health card. And if you don't have a health card, you need an address so they can mail you a health card. And they won't mail it to you if you don't have an address. So I talked to her family doctor and I said, can I have a health card sent to your office? And she was going there every 3 days to pick up her Tylenol 3s. So I knew that she would go and pick it up. And so I would check in with her and her family doctor. I would see her once a week to keep checking in on her because she had a GI bleed, likely from this colon cancer. So we did manage to get her to CT, but it was the colonoscopy that we just couldn't do because you have to have nothing to eat or drink for so long. And there were a lot of addiction issues for her to stop drinking for that long. And she couldn't do it. She had no support. She had no money for the bowel prep. And she was terrified. I remember she shared with me the reason why she was so scared of the colonoscopy because she had been raped before and she was just so afraid. And so I explained the procedure. I explained that she would have medications to put her out, but she also had no one to pick her up after she'd had sedation. So that was another huge issue. So I just kept working with the social worker to make arrangements for a taxi, for an escort, and they were going to allow that to happen, but then she didn't show up. We tried 3 different times to do the scopes. So I think the potential for access was there, and you can try to lay out a path. Everything is lined up and coordinated, but there was still a whole other part of this person, and sometimes you just lose out to the other problems. Next slide. So I think, as you heard, there's some pretty remarkable work that is being done by nurses in some cases. And yet I also want to acknowledge that there are very real constraints on nursing practice that nurses in these studies raised. Time was a huge issue, so not enough time to do anything except for addressing immediate physical needs, which meant that things like building trust with patients or addressing psychosocial issues was pushed to the side. But then nurses also talked about these sort of underlying narratives or ideas around nursing care, about what aspects of care were deemed as important. And what I mean by that is that as nurses, I think we all know and understand the importance of looking at health holistically. We know the importance of relationships intuitively, and the importance of coordinating aspects of care. I talked about that earlier. But there isn't often time for those aspects of nursing care because they aren't valued within our current healthcare system, especially within a system that is really striving for and pushing towards efficiency. And they aren't valued in a system, cancer care system especially, that is constantly looking for the newest technological or pharmaceutical innovation. Some nurses who described caring for patients with a history of trauma were left feeling overwhelmed and under-resourced. And although they didn't use these words, it sounded like they were experiencing some of that trauma vicariously without any way to really process their experiences. And then finally, some nurses seemed very frustrated with this feeling like they lacked power within their organization or within the hierarchy of the healthcare system to make changes that could improve access to care. Next slide. So switching gears again for the last time, I think there are some things that we could take away from this research, and I'd like to spend the last bit of time talking about those. Next slide. So there's sort of three main areas in terms of implications that I want to touch on. First, very briefly, policy and advocacy implications. I think influencing policy and advocating for broader changes to health systems, addressing social determinants of health is maybe not something that is the first thing most healthcare providers think of. Our advocacy is often limited to individual patients. And that is a really important part of our role, I think one that we should be proud of. But I think also as healthcare professionals, we have a huge opportunity to use our collective voice in advocating for changes that address health inequities among Indigenous peoples, along with other groups. And I think one important avenue for this type of advocacy and policy work is through our professional organizations. And so it's our role as individual healthcare providers to really ask questions of our organizations, focus their attention on policy advocacy, and ensure they're a voice in public policy debates. And I think it's also really important to remember that as providers, we're in quite a privileged position of caring for others. We witness injustices and health inequities in our everyday practice, and that really gives us credibility and puts us in a position of being able to offer solutions in terms of influencing policy. And I think we ought to be pushing to be included in those kinds of roles and at those tables. I think there's some really important policy work to be done by individual organizations or even units, perhaps things like developing anti-racism policies or ensuring that our strategic cancer plans have explicit commitments to equity and that those commitments are actually linked to meaningful actions and goals that can be evaluated. And in terms of practice implications, we know from this research and many other studies that lack of culturally safe care, negative healthcare experiences, racism, discrimination, and so on are major barriers to accessing care of all kinds, and that includes oncology care. And there are, a few ways that this needs to be addressed, but I'd like to briefly talk about equity-oriented healthcare as one potential path forward. Next slide. So what is equity-oriented healthcare? It really aims to recognize and reduce the effects of inequities on access to healthcare, as well as social determinants of health, to recognize and reduce the impacts of intersecting forms of racism, discrimination, and stigma, and the frequent mismatches between how we usually design and deliver care and the actual needs of people who are impacted by inequities. And these approaches also really make an explicit effort to build a trust, to foster safety as much as possible, and to feel welcoming and accepting for people who might be considered marginalized. Next slide. So equity-oriented healthcare is really grounded in three key dimensions, and those include trauma and violence-informed care, culturally safe and anti-racist care, and harm reduction philosophies with specific attention to reducing substance use stigma. These concepts might be familiar to you, they might not be, but how do we translate, sort of theoretical ideas into actual practice? Next slide. There is some really good work that's been done in terms of organizational level strategies to support equity-oriented care. These were not designed for the cancer care sector necessarily, but I think they have some applicability. So this would include things like, one, making explicit commitments to equity. So for example, a commitment to health equity for Indigenous populations in organizational mission statements or strategic plans. Second, to develop supportive organizational structures and policies and processes. So perhaps HR policies around hiring staff whose values align with the organizational mission, developing anti-racism policies, and so on. Revisioning the use of time. So this might mean that appointments for some patients are longer than others, depending on their needs. or there is more flexibility built into appointment scheduling processes. Next is continuously attending to power differentials. So designing organizational processes that really convey respect, for example, not staffing waiting rooms with security guards is another example. Tailoring care programs and services to local contexts. So perhaps integrating Indigenous knowledges and cultural practices into care. Maybe that includes having Indigenous elders on staff as part of the interdisciplinary care team. Actively countering racism and discrimination. So at the organizational level, mandatory explicit anti-racism training for staff at all levels, including administrators and managers, receptionists, and anyone who provides direct care. And all claims of discrimination or racism really should be taken seriously, regardless of what the intent of the healthcare provider was. Promoting meaningful engagement with communities and patients. So, for example, cancer care organizations building collaborative relationships with Indigenous communities and governments, and working to identify the priorities and the needs of that community. And that might be different than the priorities of the organization. Tailoring care to address interrelated forms of violence. For example, perhaps rethinking processes for cervical cancer screening and using HPV self-sampling instead of Pap testing. Enhancing access to social determinants of health. So at the provider level, really acknowledging and understanding that patients' circumstances affect their access to social determinants of health and care. And at the organizational level, perhaps implementing interdisciplinary team-based models of care, sometimes called wraparound care, to really address as many of those determinants of health as possible. And lastly, optimizing use of place and space. So thinking about if there's ways to make the physical space more welcoming would be one example. Next slide. And as I wrap up, I just want to acknowledge that it can be very difficult to practice in culturally safe ways and deliver care that's trauma and violence informed in the current context and structures of healthcare. Organizational and health systems contexts are often constraining our attempts to practice this way. I saw this in my own research. I talked about that earlier. And others have highlighted similar issues. In some contexts, healthcare providers are doing, exceptional work in terms of providing care that's culturally safe and trauma-informed, but they're not well supported in doing that. And that type of work is not often valued. And so I wanted to end by emphasizing the importance of taking that organizational or more of a systems approach rather than leaving it up to individual providers to work within that broken system. And that is really the focus of some of our team's work right now, studying what's needed at the organizational level to really increase capacity for equity-oriented cancer care. And so that is some of the work I'm doing with Dr. Stajahar, Dr. Annette Brown, who's one of the co-founders of the EQUIP research program, and some other collaborators from BC Cancer. Next slide, just a couple of acknowledgements. Really want to thank those who participated in these studies, many other people and institutions who made this research possible in terms of advising and collaborating and funding. And I'm going to end it there and open up for questions or comments. Oh, can't hear you.
I just take this stop sharing off. Unless people want that back, I can put it back up. But thank you, Tara. Well, first of all, for an amazing PhD project, and for some PhD students that are here on the Zoom call, it's really wonderful always to see how pieces of research projects can fit together into a coherent whole and give us a kind of a really broad understanding of the issues that are facing Indigenous peoples of Canada in terms of their access to cancer care. So I'm going to ask if anybody in the audience has questions, comments. Joanne.
So excellent presentation, Tara. Thank you very much. A couple of questions for you. Can you tell me a little bit more about where the oncology nurses were located? Were they primarily in cancer care settings, in hospitals, so that there's the organizational or the institutional aspect there? Were there any that were either going into communities or had been linked with communities or were part of the community health centers that are often in communities, like this, so that there was some relationship between the nurses, even if they weren't the providers when they got to the urban centers, if there was some kind of link between that whole system of oncology care that was there prior to the patient actually going in for whatever.
So I can't remember the exact details specifically of the survey respondents, but the people that I interviewed, so one of the requirements is you need to work in some capacity within cancer care. But definitely there were probably a third of the people that I interviewed that were in roles that were like nurse navigator roles. And so they were sort of liaising between communities. Some of them went into communities, like would fly up to Nunavut, for example. And so there was some community relationships for some of the participants, but not all. Some were very much like acute cancer care, chemo delivery, that kind of thing. So it was really quite a range.
Okay, thank you. Because I was also thinking that even if a nurse went into a community for other reasons, for education, for example, but was known to the members of the community, that may in itself give those folks giving them a bit of an edge when they have to go and seek care.
Yeah, absolutely. Actually, there's an interesting pilot project that was done in Manitoba recently where they had oncology nurse navigators going into a lot of the First Nations communities and actually training community, what did they call them? Community liaisons of some sort, and like making that like person-to-person connection, so to hopefully facilitate some access. And I think that was pretty successful in terms of building relationships and connections.
Thank you.
Any other questions? I have one.
Uh-oh.
Maybe two. Well, no, it's you don't have to say no. I'm so scary. Yeah. A lot of the examples that you provided were around rural and remote settings and the issues of like getting care for people who are out of urban centers. But I wonder if there was any reflections on kind of access to the cancer care sector for kind of urban, inner city, urban Indigenous peoples, and whether you saw any kind of differences in that.
Yeah, that did come up a number of times. Actually, the story I told from the nurse's perspective on the woman with suspected colon cancer, that was an urban residing person. And I think, you know, there was a mix of perspectives, but definitely there was this understanding that, yes, geography is a factor, but it's only one of many factors. And that, sorry, the sun is on my face, that just because someone lived in an urban area did not mean that they had great access to care. There was all of these other, you know, challenges that they still had to overcome, like that example that I gave of housing, extreme poverty, you know, trauma history, and so on. So yeah, there was definitely, you know, some that kind of saw geography as the main problem, and then many others who understood that there were, you know, sort of the intersectional nature of the challenges.
And so my next question is, and I don't know if you have an answer for it, or maybe some of the nurses that I know that work on mobile teams who are on the call might, but you know, I'm thinking about, you know, you talk about like we have this broken system, and then we have you know, people who have intersecting and compounding complexities to their lives. And that, you know, simply providing transportation is not necessarily going to be the answer. And so where do we start? Where do we start? Given that we know at the organizational level, our institutions are quite slow at responding. And I see Rachel and Kate have put their cameras on because maybe this is something they might like to talk about as well.
Yeah, I definitely do not have the answer. I think we've had many conversations about where do we start. So in the study I'm doing right now, looking at organizational context, I've talked to quite a few providers that work in community settings with people, you know, experiencing extreme poverty, homelessness, and so on. And this idea has come up on many occasions of how can we actually maybe develop some sort of cancer outreach. So we're bringing cancer services outside of the four walls of cancer agencies and into the community. What exactly that will look like, I don't know, but I think it's definitely an avenue worth considering and pursuing. And that would take a lot of collaboration with people who work in the community. I don't work in the community, I never have, so I don't have a great understanding of what that would look like. But yeah, if someone wants to chime in and give their perspective, happy to hear that.
Amber, Kate, Rachel, anyone else?
I agree. Yeah, I think cancer outreach would be really helpful for many different reasons. I think it would be interesting to see how it could be coordinated. I think often one of the challenges we find working with, I mean, there's many challenges working with many different areas of the system, is sort of when that handover happens from the cancer agency to the community. Any handover is a time of potential breakdown in communication, but like, when is that happening? How is it happening? Who's taking over service? And then vice versa. And there's a disconnect between what the environment looks like in the community and how the client presents at the cancer agency. So are they going to be offered treatment? What does their home situation, quote unquote, look like? And decisions being made about whether treatment is feasible or not based on that. And it's just, I think it would really help to facilitate trust. Like, coming out to meet someone goes a long way, and then vice versa. So I don't know. I think there's something to it. I think having clinicians that can follow for longer periods of time is really helpful. And we see a lot of, in Victoria, certainly right now, a lot of oncology cycling. So there's a lot of changeover, and that's challenging as well. So if we could get some continuity of care, I think that would be really helpful. But it seems like until they're sort of palliative and we need symptom management, when we ask for that, we generally get a pretty good response. So we're really lucky to be in a major center. I can't imagine what it would be like working rural and remote for these clients. Transportation in an urban center in and of itself is challenging, let alone getting someone from North Island down to Victoria for urgent radiation. I can't imagine what that would look like. Yeah.
Amber, were you going to say something?
Yeah, just to add to kind of like the complexity of the current climate right now in oncology is, you know, it's sort of, and I'm kind of loving that these conversations are happening in tandem because in one way, you know, cancer rates are rising due to an aging population. We've certainly felt the effects of that in BC, as I think, you know, during the pandemic, a lot of people also moved to BC as well. And we're just experiencing kind of an influx of patients we can't keep up with at the cancer agency. And we've had wait lists for the first time ever. And I think now more than ever, people are actually starting to realize that the same way that we've been doing things cannot be moved forward even for all of the people in BC. And so it's actually very good to kind of think about outside the box of thinking of just how we can deliver better care for everybody, and including that, there isn't a one size fits all protocol. And so there's some things that I'm encouraged to see kind of from within the cancer agency of, that basically we're at a crux of needing to change, which is a good thing, but also that individual conversations I've had, and as we're kind of bringing some of these issues to light, that people are kind of thinking like, this also, equally is unfair, unjust, and I don't want to practice in certain environments that cannot deliver care. So, and that's directly from healthcare providers. And so I think that there is an appetite, definitely, to be moving in a direction. And thankfully, Kelly's program of research and has paved the way forward for actual practice change in the palliative care setting. And so at least there is some sort of, blueprint for how maybe that research can translate into clinical practice settings that actually improve care, and address social and structural determinants. And I think that basically there's always, at the end of the day, is like, who funds roles? You can find people that want to do work, but yeah, it's going to be the case of like, and I hate that conversation so much, like, who's going to pay for it? Obviously, we would like the cancer agency to be paying for these types of more outreach roles, but it's just it's just very complex, but it's really good to have a conversation about what is needed. And then, from both angles, I think.
Yes, absolutely. And having worked in the cancer care setting for about 10 years, I think Kelly has made a really good point. Like, we do need to have those conversations, and we do need to think about organizational change. And at the same time, that is going to take a long time. There's also a lot of very entrenched views about how things ought to work, and not always a willingness. Not to say this is everyone, because there are definitely people who within the cancer care sector who are forward thinking and who are really coming to understand the depth and breadth of health inequities and what that means, that we ought to be doing something about it. But then there are others that don't share that perspective. And if you would raise the idea of a cancer outreach service, would be probably quite put off by the idea. So I think we have a huge challenge ahead of us. Yes, you want to make one more comment?
And then we go to Rachel, who's got her patiently waiting with her hand up.
Right. When I've talked to providers, they actually do have an appetite for that. So I think that is also really encouraging. Oncologists are like, yeah, obviously we should be doing outreach into the community and have that part of a role. So it's not everyone, obviously, but thankfully there are people that do think like this.
Yeah, and I think we're moving towards that critical mass.
Rachel.
Thank you. I was just thinking about the outreach component of it. And I know here in Alberta, we do have the MAN van. So it's starting with sort of different kinds of cancers. And I wonder if that could translate into, sort of more broad screening. So our MAN van does actually come out to our remote reserves, which is really interesting, I think. So I wonder if there's, some creativity, could we sort of adapt to that model? But then I was also wondering, in the past 2 years of COVID, where more things have gone virtual, is there an increased appetite for reducing the number of visits that people have to use, and using that an echo model for those remote locations?
Yeah, I think there definitely is. And at the same time, we have to be careful about relying on that as the strategy, especially thinking in terms of Indigenous communities. I'm speaking from a Manitoba perspective here, because that's what I know best, but there are still some communities that do not have internet. And so, that could work really well. And then for other communities, it's just not an option right now. So it's perhaps one of several solutions. And I think it was pretty well used in Manitoba's case anyways, pre-pandemic, probably is more so now, but then there are some people that still isn't going to work for. I think it just points out the danger of thinking this is the pan solution, you know?
Absolutely.
Yeah.
We recognizing that not everybody has excellent internet access or even the infrastructure, you know, computers and that sort of thing. On Siksika Reserve out here, we use the community paramedics, and they attend the visits with clients. So they bring all the infrastructure, you know, the remote hotspotting, the laptops, and Zoom in to you know, to appointments in the city. So maybe there's some opportunity there. It's kind of interesting.
Thanks for that.
Yeah, I think it's and we probably have to wrap up soon, but it's really about like how creative can we get with like what's already existing out there. Like in Alberta, like there's a very awesome paramedic service that is doing a whole bunch of things outside of the scope of what we have historically thought of as paramedic services. There's also, you know, communities of people, you know, if you think that, you know, that if you look at kind of developing countries where, say, rural women are taught to do pap smears because their clients have no trust in the providers, and you know, and they're able to take a picture on a phone and upload it and send it to a radiologist in the UK who can say if that person needs a cryotherapy for a possible cervical cancer. Like if those kinds of things can happen elsewhere, why are they not happening here? Like I think sometimes we have to look outside of what we think, you know, we do in our settings to look. And I often find that those innovations tend to be in small communities, because people don't want to leave. And, you know, anyway, Tara, any last comments, questions before I thank Tara? Okay, yeah.
Can I just say one thing? And this is something that's kind of come on my radar a little bit more lately, is just the actual sharing of health records between organizations and agencies. And there's a lot of lost information in that process around things like the social determinants of health. And I mean, it's one thing for an oncologist to hand someone a prescription for ondansetron when they have no coverage, and for them to walk out and be like, this isn't ever going to happen. Like, access to medications, we should have a way more streamlined process for understanding, like, okay, I'm not going to prescribe this because they're not going to fill it. It's not covered. Like something as simple as that could be solved with support from health informatics and bringing that to the table around communication. And yeah, I just think there's some like low hanging fruit that we could tap into. Not me per se, but
or me. Yeah, but not to mention how much time that would save.
Yeah,
you know,
anyway,
like I'm thinking about this home care study I'm doing, and it's like how much time people are spending just trying to find information because it's located in so many different spots in this kind of hybrid electronic paper and even sticky note system.
Yeah. Actually, that came up in our workshop that Amber and I facilitated yesterday. Even, how can you create an electronic medical record that might be shared, but also that a system that can actually flag someone that has additional needs and specific requirements for care in a way that every single provider actually sees, and it's not just buried in the chart somewhere, and then those things don't get addressed.
That's exactly it. To put in perspective, I'm in one organization and I have 3 different logins for 4 plus a paper chart just to look at one patient. So if you don't want to log into different things, like things just get messed, and it's very time consuming.
It's such a time sucker. It's if we think that we have a time issue in healthcare, we actually have an issue where a system is not there to support us to do the work. If we didn't have to spend time doing that, we might be able to spend actually more time with the people that need us. Okay. Great. Thanks everybody for attending our first little seminar, and hope whoever isn't connected to our team will sign up for our newsletter, and we'll be putting those kinds of things out. Next week, actually, we have a postdoc from Sweden who is here visiting us, who does a lot of really cool arts-based kind of intergenerational arts-based methodologies around end-of-life care. So if you have any interest in that, or you just want to learn about kind of intergenerational arts-based work, Max Kleinberg is a wonderful speaker, just like Tara, and we absolutely welcome you back here.
Thanks, everyone. Really appreciate it.
All right. Thanks.
Bye.
Bye.
Yeah.